Thank you, Dr. Ehrlich. Good morning, everybody. Good morning, Scarborough pediatricians. Good morning, family doctors, nurses, friends, colleagues. I'm so happy to be here today. I was told to come back and talk about spitting babies this morning, but clearly Dr. Ehrlich is the one who should be speaking because I don't have any grandchildren yet. Having said that, before I get into my talk, I want to emphasize the same message I gave last year. The most important reason why we're all here today is because we can say hi to each other. We can connect, we can shake each other's hand. You can remind me that you share patience with me, and I encourage you to take that moment to do it again this year. When you do that, and then I see your patient, and I see your name as the family doctor or pediatrician, I feel internally more obligated to try harder. Okay? I feel like, oh, I met them in October, I better do a better job. And I think that ends up resulting in better patient care. And that's what we're all about. So please, if you have a moment, tap me on the shoulder, say hi to me, reintroduce yourself, and I think it's going to be better for all of us as we do our work. I have no disclosures, and the objectives this morning are very simple. I'm going to talk to you about the key points in infantile gastroesophageal reflux disease, mainly because there's been an update as of last year from the North American Society of Paediatric Hepatology, Gastroenterology, and Nutrition. The update isn't terribly earth-shattering, but it's important to make sure we're all on the same page and up to date. I'll also talk about when you should be referring onward. The type of baby I'd like you to stop and think about walking through your door with their mother would be the 3-month-old, who the mother says is vomiting after meals, isn't really happy and crying and arching a lot, maybe having good days and bad days. And sometimes when you offer the nipple, he gags. Other times you have to really push the bottle because he's not interested in taking it. Maybe the weight is the lower range of normal. And you see a little bit of eczema on their face and on their skin, on their feet. Just to make sure we're on the same page, gastroesophageal reflux is simply the backward motion of your stomach contents up into your esophagus. If you add a D for disease, then you're having troublesome symptoms or you're leading to complications. Just to be clear, gastroenterologists spend a lot of time thinking about this, and spit up is low force reflux out the mouth, okay? Vomiting is high force, and then regurgitation is reflux, but it doesn't pass the lips. It only goes into the pharynx or into the mouth, but not out the lips, okay? And I'm thankful that I was given the talk where I actually have a superhero. This is Reflux. He's from Incredibles 2, for any of you who've watched the movie, okay? And his superpower is that he can vomit acid at his enemies. So I think that's really neat. I know it's early. I know you guys all know how to manage reflux. A lot of this is review. So I'm just going to give you 10 pearls, just like our conference title says, and then you're good for the races. Pearl 1, don't drug happy spitters. I think you all know this, but now you can pull up my slide and show the mother and say, Dr. Yeung says don't drug happy spitters, and then you're good, because happy spitters are fine. We don't need to do anything for them. Because spit happens, and the question we have to ask is it troublesome? And troublesome is a spectrum, right? Crying and irritability is kind of troublesome, but we're not sure if that warrants management and treatment. If they're not feeding, or they're arching, they're vomiting, that's more troublesome. And then if they actually demonstrate weight loss, or they're refusing to feed, or they're not sleeping well, that's very troublesome. Pearl 2, heed alarm features. The guidelines have a clear table of alarm features, which I've reproduced here. The reference for the guidelines is in the right lower quadrant. And most of these can cover infants. Many of them may be more applicable to older children as well. The bottom line is if you've got weight loss, lethargy, fever, if there's a lot of irritability and pain, you have to think twice. Maybe something beyond reflux is going on. Obviously, if it's forceful, persistent vomiting, if they're vomiting blood or bile or at night all the time, if there's diarrhea, rectal bleeding, or abdominal distension, you have to think a little harder. Neurologically, if I find a bulging fontanelle or a seizing child or a big head or a little head, I'm calling neurology right away. So you want to test and you want to refer onward for alarm features. Pearl 3, warn them it gets worse before it gets better. This is really important. If you don't do this, they'll think you're a terrible provider. I brought my baby in at 3 months, went home, the reflux just got worse. What kind of doctor is that? You have to tell them. We have population-based data that shows reflux peaks around 3 to 4 months of age, and it gradually gets better over time. And there's physiologic reasons for that. At 6 months of age, they're tripod sitting. Gravity is now on their side, so they're not going to be as easily able to reflux. And so you have to tell them at 3 months, it's going to get worse. And then after 6 months, you'll start to get better. And after a year or 14 months, hopefully you'll outgrow the problem completely. Pearl 4, change position. By the time the patients come to see me, most of the families have figured this out. But when they come to see you, they might not have entirely realized this pearl yet. And so you can tell them, after feeds, keep them upright. A baby carrier where you can strap your baby to you and remain upright is really helpful. The car seat angle, about 45 degrees, is really bad for reflux. It allows the lower esophageal sphincter to be wide open and the stuff in your stomach goes right up. So unless you're in a moving vehicle, maybe avoid the car seat position for these babies. We know that babies with reflux will reflux less if they're sleeping on their belly. Again, anatomically, the lower esophageal sphincter is more closed. However, the risk of SIDS is bigger than the risk of reflux. So we still ask these babies to sleep on their back. Pearl 5, thickened feeds. This recommendation generated a bit of controversy before the last guidelines, but at the end of the day, even if thickening feeds doesn't change your pH probe result and change reflux dramatically, we know that it decreases the episodes of vomiting and irritability. And talk to any parent, and that's a good enough outcome to do something. So it's either a teaspoon or a tablespoon of rice cereal per fluid ounce of formula. And if you have breast milk, then you can add in something called carabine thickener, because the amylase in the breast milk will digest the cereal. And most importantly, remind them not to overfeed. By the time you get to someone like us, we like slow, frequent meals. We like continuous feeds because it's easier on the gut. And so sometimes families just need to know they have to back off in terms of volume per feed and just feed more often. Number 6, change the formula. Allergy can look like reflux. We can't pick apart the kids who have cow's milk protein allergy and just plain old reflux. So a 2-week trial of some type of intervention to avoid cow's milk protein is really valuable. This is one of the biggest messages the new guidelines have sent out. Give the change in formula a try. And if you're breastfeeding, mom goes off the cow's milk protein in her diet. If you're doing formula, you can go hydrolyzed, or you can go amino acid-based formula if necessary. Number 7, limit the meds. This is the other big guideline outcome, okay? When you look back at the last decade or two, it seems like every type of doctor was giving every type of acid blockade, especially proton pump inhibitors, to everybody forever. And this generated a lot of controversy and concern. And then people doing administrative database research said, if you are using an acid blocker PPI, let's pick an outcome, any outcome. Let's see if there's a relationship. And we found all types of low-level relationships. Not necessarily causation and all, but it raised a lot of concerns. So as a result of all this, and probably any medication taken too long with no good benefit is not a good idea, this is the strong message from the latest guidelines. So they want you to do a therapeutic trial, limit it to 1 or 2 months of acid blockade. We know from endoscopic data, scoping these kids every month, that it takes about 2 or 3 months for erosive esophagitis to fully heal. So after 2 or 3 months, you should be done. Furthermore, the evidence suggests that PPI use in babies has no benefit. That's 4 randomized controlled trials, meta-analysis. It's hard to know if acid blockade really helps these babies anyway. We don't have good evidence for that. Although, anecdotally, we all know parents who say, if you stop the PPI, I'm going to freak out. We know this makes a life-changing difference in my kid's quality of life. So you have to check it out for the patient. There are risks to potential chronic acid blockade that require caution. And as soon as the patient's better, you try to wean off the medication as tolerated. My spiel to families on PPIs is the usual risk-benefit ratio. I talk about how your child might benefit from it, and then we look at the risks. We have good data in lots of kids taking PPIs for over a decade because they need it, and the drugs are safe, no adverse effects. However, case control data shows that PPIs will increase your rate of infection. And in babies in the NICU on ranitidine, the risk of necrotizing enterocolitis does go very high. So you really need to think twice. People who are more at risk of upper respiratory tract infection, sepsis, UTI, Clostridium difficile, all those patients, maybe a little bit of acid blockade, but not more than necessary. In the adult data, PPIs have been associated with an increased risk of fractures, dementia, cardiovascular events, renal disease, and certainly for children, there's some data to say osteoporosis, thinner bones, poorer DEXA scan results do affect children on chronic acid blockade. And the idea is too much acid, not enough calcium absorption, thinner bones, more fractures. So for those patients, I tell them, well, if you really get a benefit from your acid blockade, then you need to consider yourself like the patient who has a family history of osteoporosis. You are at risk. And what are you going to do? You're going to take more calcium, more vitamin D, more weight-bearing exercise to mitigate that risk. So you want to have an intelligent conversation about that. And then any patient I have on chronic PPI, I bring back once a year to make sure they're growing, to make sure they're well, to make sure they're trying to wean off, and to justify that they still need their medication. Furthermore, last month, they were testing ranitidine and they found NDMA, nitrosodimethylamine, at low levels in ranitidine. That's why we can't get Zantac anymore. And this is a probable human carcinogen. It's a known contaminant. It's in our water, it's in our food, our meat, our eggs, our veggies, our dairy. And the low levels the FDA has found are not felt to exceed the amounts we find in foods. So overall, we don't expect any harm from this ranitidine at very low levels. But to be cautious, they've recalled all the samples and they're testing and investigating. And so if you need to use ranitidine, you need to think a little wider and maybe use something else. Famotidine is an option, and then there's all your PPIs. Omeprazole comes as a solid form and liquid. The lansoprazole can be solid capsule. The capsules can open up and granules can be mixed in with yogurt. And then they also allow you to take the dissolvable tablets and put it in water. Esomeprazole comes in a pill form as well as a sachet form that can be mixed in water. And then we have pantoprazole in solid and I believe IV formulation. Perlate, beware of triggers. You also have to warn families of this one. These are the top 4 triggers patients tell us bring on their reflux again. So infection, cough, cold, runny nose, not enough sleep, stress, an asthma attack. So all my reflux patients in high school during exam time, they all need their PPIs, okay? You cover them for 2 to 3 weeks, the stress is over, they're much better. Pearl 9, same as last year, refer as needed. And you should refer if you see alarm features. You should refer if you've tried your 4 to 8 weeks of acid blockade and you're not getting anywhere. If you can't get off the medication, or maybe if the family just needs more reassurance after you've showed them all my slides. And then Pearl 10, consider EConsult. My husband, who's a medical school classmate, when he found out about EConsults, he said, oh my God, it's like having all the smartest kids from med school, like right there electronically available for you to ask questions. And I think he's right. There is a bit of a learning curve to get an account. They have to make sure you're legitimate, you're actually a healthcare provider, you're not trying to hack the system. But once you get in, you have wide access to every specialty you can think of, including pediatric GI. You can pick your doctor, or you can just get a specialist, and they will farm it out to whoever's available. And you can ask your question, you can upload your documents, and response is usually within 48 hours. I provide a lot of e-consults. I find them incredibly smart, saves the patient the trouble of waiting for my appointment in my clinic room. You get to keep the patient because you know the patient better anyway. You know what you're doing. I just have to give you a little bit of reassurance or remind you of a little detail here or there. And with this referral, you get to bill a little bit. So I really think it's a win-win scenario. I do have cases where after e-consult, we still need to bring the patient in. But by that time, I kind of know the patient. You know, maybe I can accelerate and triage the patient because I just know they need a scope and we can facilitate. So if you haven't tried e-consults, I really encourage you to give it a consideration. So back to our baby, 3-month-old, vomiting, not happy, maybe having a little bit of feeding refusal, weight's kind of borderline, maybe some eczema. Now you know what to do. Pull up my list. Don't drug the happy spitters, but he's not that happy. heat alarm features. He doesn't have any hard ones, but we're going to monitor. Warn him it gets worse before it gets better. Teach them to watch the position, use gravity, thicken the feeds, 2 weeks of a formula change or a feed change. Take away that cow's milk protein. If necessary, try some medication for a month or two, and warn them to watch out for triggers, because reflux will get worse when that happens. And if you're still stuck, then bring them on, and I'll do what I can. Thank you very much for your attention. I welcome any questions.